Is Michael Ammar. I'm a vitreoretinal surgeon at Retina Consultants San Diego, and I'm going to be chatting with you today on updates on the management of diabetic retinopathy. I have no relevant financial disclosures. And so just a brief overview of what we'll be talking about today. We'll talk about the state of diabetes in 2021, a little bit on the current state of diabetic retinopathy and how we manage that at this time, or at least have in the most recent past. We're going to talk about some of the challenges we face with our current therapeutic regimens and treatment paradigms. And excitingly, we'll talk about what's around the corner, what's on the horizon, what are some future treatments that are coming down the pipeline potentially for diabetic retinopathy. In 2018, 34 or so million Americans were found to have diabetes. It's about 10% or so of the population. A very significant population. And we know the majority of these patients who have diabetes have type 2 diabetes, with the minority having type 1. And unfortunately, the rates are rising. In both adults and teenagers, we're seeing diabetes on the rise and diabetic retinopathy on the rise. When you look at mortality rates and things like that, 2 million deaths per year attributed to diabetes. We know that those with diabetes have a lower life expectancy and that they often have significant comorbidities. So as we know, just a significant challenge to our population, and a lot of health issues are associated with diabetes. More relevant to us in the fields of eye care is diabetic retinopathy, something we see in our clinics, something we deal with all the time. And there are a lot of challenges we face dealing with diabetic retinopathy in this patient population. A big one for me is education, communicating to patients what it means to have vision loss when they're seeing 20/20 and they feel fine, but you look in on their eye exam and you can see that diabetic retinopathy starting. Maybe they have some early changes, and even though they don't have any symptomatic changes based on their A1C, based on their blood sugars, from numerous studies, we know that they're at risk of progressing. And I've always found it's hard to communicate to someone what that change in vision is. What does it mean to have a vitreous hemorrhage? What does it mean to have macular edema? And just to kind of demonstrate an image that I personally love is what you're seeing here on the screen. This is from the top of and I may butcher this pronunciation, the Haleakala volcano in Maui. And it's a beautiful place where you can go to the top of this volcano and you can watch the sunrise over the clouds in the morning. And it was just a breathtaking experience. And another photo just for demonstration is, so full disclosure, I was born and raised in the desert. I'm from Arizona, and then I was in Southern California. So until I went to Philadelphia for my residency and fellowship, I never saw, falling snow. And the first time I saw it, I was so mesmerized. It was a breathtaking thing. And for those of you familiar with Philadelphia, this is the Schuylkill River you can see there, and a little fly equals fly billboard as a clue to Philadelphia. And so these are just two images I'm kind of using to demonstrate what those changes can look like. So what is a vitreous hemorrhage like? And it's hard for patients to appreciate. Very suddenly, very rapidly, they can have a significant change in their vision. Big blotches, and there's a spectrum. If they're lucky, maybe they're just floaters. Sometimes it's as bad as, count fingers vision in their entire visual field. What does it mean to have something like macular edema, where their entire vision can be significantly altered? And I think these are hard things to communicate to someone who's never had vision loss, and that all comes from the education. And so diabetic retinopathy is the leading cause of blindness in working age populations, which is a unique challenge for this population. We'll talk about that more later because it makes the treatment demands very difficult for them. Surveys have shown that over half of patients with diabetes are unaware it can lead to vision loss. Risk factors for diabetic retinopathy include duration of disease and blood sugar over time. These are things we know. And the longer you have diabetes and the worse your blood sugar control, basically the risk of your retinopathy and your complications, not only in the eye, but elsewhere, go up. And unfortunately, we often see patients present with advanced disease that could have been prevented if they had presented earlier. And that's always an unfortunate situation. Oftentimes, had they had appropriate care, follow-up, management early on, we could have prevented them from reaching, more terminal stages, something like an advanced tractional retinal detachment or significant ischemia. And the consequences and complications of diabetic retinopathy are vast, from non-proliferative diabetic retinopathy through, PDR, diabetic macular edema, vitreous hemorrhage, TRDs, neovascular glaucoma. It's a long list of direct and indirect consequences of diabetes. So now let's talk a little bit about how we manage diabetic retinopathy currently. So the ETDRS study, or the Early Treatment for Diabetic Retinopathy study, created a scoring grading system to assess severity of disease. And it was a multi-center randomized clinical trial looking then at laser photocoagulation in the management of patients with diabetic retinopathy. And we got this diabetic retinopathy severity scale out of it that we still use today. You can see on the left there, there's a numeric score, which many people don't really use in their documentation in their clinics, but we do use the terminology, which has kind of been simplified to be sort of mild NPDR, moderate NPDR. Most people just kind of group moderately severe and severe into severe NPDR. And then of course we have the PDR categories. And so, this is a common thing we all stumble upon. Mild non-proliferative diabetic retinopathy, you could almost miss it if you weren't looking closely. It can be just a few microaneurysms, a subtle dot blot hemorrhage, sometimes can be a very subtle finding. And I think across the board, most people just observe these patients. Obviously, in all these stages, you're counseling systemic management, follow-up, things like that, medications. But in regards to the eye, observation. For moderate non-proliferative diabetic retinopathy, we're seeing a little more damage now, right? Some more advanced hemorrhages, maybe some cotton wool spots. And you can appreciate that on these images here. But again, observation, for the most part, people would observe these patients. Severe non-proliferative diabetic retinopathy is where things may diverge a little bit, at least for some people and in certain situations for certain patients. And we'll talk later on about, potentially some additional changes coming this way. So maybe people now would consider laser in the right patient, in the right population, putting in PRP, and then maybe some additional therapeutic options, which again, we'll talk about later. PDR and tractional retinal detachments, this is where you're starting to consider things like surgery. These are very sick eyes. You can appreciate here the tractional membranes, the neovascular areas, and obviously, these can be very challenging cases surgically, and oftentimes there can be some degree of permanent vision loss. But some combination of anti-VEGF, laser, and surgery is how we manage these patients. And then diabetic macular edema, you can appreciate here the diabetic retinopathy on the fundus photos, and on OCT there, you can appreciate the center involving DME. And depending on the patient and their response, some combination of anti-VEGF, steroids, and or laser are often used. And this is just to kind of lay everything out on a spectrum for you with that diabetic retinopathy severity scale, sort of how we document diabetic retinopathy, and then fundus images. So you can appreciate, you can go from basically diabetic retinopathy being completely absent all the way to having advanced PDR and the scores and the terminology associated with that. So what are the challenges? I think that was just kind of going through briefly how we currently manage diabetic retinopathy, what the current state is. And there are challenges. We don't have perfect treatments. First, treatment burden. It's important to appreciate that this population is not the macular degeneration population. This isn't AMD. These aren't patients who are retired, who, though they may not like coming in, their schedule is often a little more amenable to coming in monthly if they need to, which some patients do for injections. They don't have people dependent on their salaries, on them working. And diabetic retinopathy patients often are people working age who have a hard time taking off work. You're asking them to take off a weekday, a working day, because it's hard to take off part of the day, or at least part of their weekday, to come in potentially once a month or every couple months, depending on their disease. And so the time to them is significant, and cost, cost to them, cost on the healthcare system of potentially, monthly or every other month or so injections in the management. I mean, it's a big burden. And so that's a big challenge with our current treatments. Efficacy, while our treatments are effective for a lot of patients, they're not perfect. Some patients are just kind of partial responders, despite treating them with anti-VEGF, despite treating them with steroids. they continue to worsen or they don't get a complete response. I mean, I think we're learning more and more. There's just a lot going on in diabetes that's outside of the realm of our current treatments. There are pathways potentially and factors that we are not addressing. And so efficacy, for sure. Durability, a big one. Some patients have to come in almost monthly, and otherwise they start to have worsening vision. So can we generate treatments that can last longer and have fewer visits? That's a big challenge. And loss of follow-up, which is kind of a culmination of all the other challenges. This burden growing on these patients who are working and busy families, they eventually find it to be too much to bear and they stop coming in. And what's sad is when they do come back in, they often have a significant progression or a significant vision loss. Some great works come out of Wills with Jason Shu and others, and so many other institutions demonstrating this, that we know it's a problem. Patients get lost to follow-up, and then when they come back in, things are worse. And so by improving our treatments, maybe we can improve our loss to follow-up rates, and also by addressing that through other means like education. So now, a little more fun and more excitingly, what's new? What's around the corner in terms of changing current treatment paradigms and maybe new treatments altogether. So the Panorama Study is something I think we should all be familiar with, because it brings up a very interesting thought process that may change treatment paradigms. So the study looked at 402 adults with diabetic retinopathy considered to be, severity scale score 47 or 53, which essentially is moderately severe or severe non-proliferative diabetic retinopathy. These patients had no macular edema and their vision was 20/40 or better. So essentially good vision, NPDR, no macular edema. And they asked, does the treatment of NPDR with intravitreal aflibercept improve their diabetic retinopathy severity score? Essentially, can you move the needle back in regards to their progression of diabetic retinopathy if you treat them with anti-VEGF? Can you take someone who's severe NPDR and move them, let's say, to mild just by treating them with anti-VEGF? Obviously, you're always encouraging systemic treatment as well. And let's looked at this over 2 years, and there were 3 treatment arms, essentially one that after a loading phase became Q16 week with intravitreal anti-VEGF or aflibercept, one arm that was a loading phase that was a little longer, and then was Q8 weeks, so more frequent dosing until week 52, at which point it became PRN, and then a sham arm. And these are the results. So this is looking at the proportion of eyes with a 2-step or greater improvement in their diabetic retinopathy severity scale score. And you can see here that in the sham eyes, the proportion of eyes that had a 2-step or greater improvement was low, under 10% at 24 weeks, at 52 weeks, and then 100 weeks here, always well under 20%. If you look at the aflibercept arm dosed Q16 weeks, significantly different, right? Over 60% of these patients had an improvement, 2 steps or greater in their diabetic retinopathy severity scale score. And in the Q8 week arm, at 1 year, you can see it was almost 80% of patients had a 2-step or greater improvement with intravitreal aflibercept. And when they switched to the PRN dosing, it dropped a little bit here. But compared to sham, as you can see, a big difference. This is another graph here looking at visually threatening complications through week 100. And you can appreciate that in the sham arm, the cumulative incidence was significantly higher than the aflibercept arms of developing things like vitreous hemorrhage and other complications. And this is looking at center-involving diabetic macular edema through week 100. And again, showing the same. Patients in the sham group significantly higher than those in the aflibercept arms. So the primary endpoint for the Panorama study was the proportion of eyes with a 2-step or greater improvement in the diabetic retinopathy severity scale score from baseline and the aflibercept groups compared with the control group. And it was met. And at week 100, they showed that this improvement was maintained with both aflibercept dosing strategies, and they had a significantly lower incidence of visually threatening complications in center-involving DME when compared to the control group. Based on this data and this study, the FDA approved aflibercept to treat all stages of diabetic retinopathy. So as of now, you can treat diabetic retinopathy with anti-VEGF on label, and that has been addressed by the Panorama study. Now, most people are not doing that, and that's a different matter of discussion and debate as to, which patients we should do this for and how we should be doing that. And that's something that's coming up a lot in discussions and surveys and conferences, but we have data that showed this. Now, what are the thought processes in regards to potentially changing the treatment paradigm? Some argue maybe we're too reactive to how we're approaching diabetic retinopathy. We wait for the damage and then we treat. Maybe we should be being a little more preventative and treating with these anti-VEGF injections earlier on, maybe at moderately severe NPDR. And so that's the argument. And out of this argument came another study, the DRCR Protocol W. And DRCR Protocol W brought up an interesting point. The Panorama study didn't look at visual acuity outcomes. It looked at diabetic retinopathy severity score, visually threatening complications, DME. Protocol W was similar. It looked at 399 eyes with moderately severe to severe NPDR without diabetic macular edema, good vision. But additionally, they looked at visual acuity outcomes. And there were two treatment arms, essentially sham or treatment with aflibercept. And this is just showing that the, essentially was pretty evenly split between the two arms, whether they were in the treatment arm or in the sham arm. And this is a table here looking at the graph, looking at the time to proliferative diabetic retinopathy or center involving DME with vision loss. And you can appreciate that the sham arm here had a higher cumulative probability of developing center involving DME with vision loss or PDR at 2 years compared with the aflibercept treated arms. And this is just looking specifically at the time to proliferative diabetic retinopathy. And again, showing the same thing, that the sham arm had a higher cumulative probability than the aflibercept treated arm. And this looking at the time to center involving DME. And you can appreciate not as significant a difference here, but that the sham arm again had a higher cumulative probability than the aflibercept treated arm. But this is, I think, the graph that maybe is most important to take away from this study, that the mean change in visual acuity through 2 years was very similar. So at 2 years, whether you were treated with aflibercept or sham, there was not a big difference in mean change in visual acuity. There was not a statistically significant difference. So while the Protocol W data supported the Panorama findings that the diabetic retinopathy severity scale score improves if you treat eyes with diabetic retinopathy with intravitreal aflibercept, a statistically significant difference, improving 2 steps or more. They showed, and this was not really looked at as a primary outcome in Panorama, that the mean change in visual acuity from randomization to 2 years was not statistically significant. So though you're improving the diabetic retinopathy score, though you're preventing visually threatening complications in DME, they didn't show that there was an actual benefit in visual acuity. And this is kind of just demonstrating that. Now, obviously there's a lot to debate and discuss about that data. Is vision just visual acuity? There are other aspects of our vision that isn't measured on a Snellen chart. And you can't discount the fact that you're improving diabetic retinopathy scores, avoiding visually threatening complications, center involving DME. But you can also argue that, again, Protocol W didn't show a change in visual acuity. And so a lot to discuss, a lot to think about, but certainly something everyone should be keeping in mind, that it's on label and now approved to deliver intravitreal anti-VEGF for diabetic retinopathy. So now that we've talked about potential changes in our existing treatment paradigms, let's talk about some possible future treatments, things that could be around the corner, some exciting new technologies, and some potential big shifts in the way we both approach and manage these patients. So high dose aflibercept. Aflibercept is something we're comfortable with, right? We've been using for a long time, but some people have thought, well, maybe if we use a higher concentration of aflibercept, we can have higher efficacy and potentially higher or better durability. And Photon is a phase 2/3 clinical trial evaluating high dose aflibercept versus standard dose of aflibercept for diabetic macular edema. We already know it's highly effective now for diabetic macular edema, and as we just discussed, diabetic retinopathy alone. But maybe higher doses can do better. And these trials are currently being undertaken, and we'll see results in 2022. And this is a nice trial because it's a drug we already know is safe. We have a lot of real world data and experience with. And so it'd be something I think a lot of people would be comfortable adapting to. Let's talk about brolucizumab now. Obviously, there's, as many have heard, potentially there's a lot to talk about with brolucizumab, and we'll get to that. It's a novel treatment for anti-VEGF, intravitreal injection, and there are a number of phase 3 clinical trials being undertaken currently looking at the treatment of diabetic macular edema with brolucizumab. And early results have shown that it's non-inferior to aflibercept and possibly more efficacious. It may work better or at least have higher durability, but we can't talk about brolucizumab without addressing its side effects. So it's been approved now for neovascular AMD for some time. And while in the studies, patients were pretty safe, there weren't a lot of safety issues, I should say. In real world data, we started to see something when it first got on label. Patients or providers started reporting these events, these cases of retinal vasculitis with occlusive events that were very striking with significant vision loss. And to their credit, Novartis and retina societies and everything were very on top of this, encouraging reporting, looking into it. And unfortunately, we still don't fully understand why this happens. We know that patients with inflammation are at higher risk. And so that's something that's a big thing to look for any evidence or a history of inflammation. We know that in these macular degeneration patients, the risk is about 1 in 200 or so of developing significant vision loss from these retinal vasculitis and occlusive events. However, despite this, it's still on label and you can still use it. And so with all of that in mind, possible FDA approval for diabetic macular edema, not currently, but that's something we'll wait and see. And whether or not people adapt and use this is a matter of personal choice, and I think good education and discussion with patients. The port delivery system, very exciting technology, and we'll talk about that. Very recently was just FDA approved for the treatment of AMD, but PDS, as it's called for short, is a first of its kind anti-VEGF system that allows continuous release of ranibizumab into the vitreous via passive diffusion. A very exciting and new technology. It's been shown to reduce the frequency of intravitreal injections, potentially allowing patients with DME to go, several months, 6 months or so without needing a refill of the implant. So you could have patients who are on monthly dosing now going out much longer. We're talking about a huge increase in durability. The implant can be refilled in the clinic, which is very convenient. However, it does need to be surgically implanted initially in the operating room. The phase 3 clinical trials, Pagoda and Pavilion, evaluated the PDS implant for diabetic retinopathy with and without DME. And again, as I mentioned, it's been FDA approved for AMD as of, I feel like it was a few weeks ago. It's a new technology that's been FDA approved in a field where we haven't had a lot of big new players in a long time. And so I think there are a few things we need to keep in mind with the port delivery system. This is just to demonstrate kind of how that looks. And a scleral incision is made in the OR, and the implant is embedded in there and covered with the conjunctiva. And then in clinic, there's a refill needle that can be used to kind of refill the implant with a reserve to then be, again, passively diffused over a number of months. I think the real world data will be very interesting to see how these do now that they're FDA approved and people start putting them in. One thing to keep in mind is their study, and this is, I think, on the box, had a statistically significant higher rate of endophthalmitis compared to something like intravitreal injections. And so that's, I think, something we'll be watching along with other factors in regards to real world data, but very exciting technology. And can't wait to see, the data that comes along with this. Furicimab is the first bispecific monoclonal antibody designed for intraocular use, and it's been submitted for possible FDA approval. So Furicimab is very interesting. In addition to targeting the VEGF pathway, it's bispecific in that it also targets this novel pathway, which we really haven't approached before, the Ang2 Tie pathway. And the combination is thought to be synergistic. Essentially, Ang2 is thought to contribute to vascular instability. So Ang2 is thought to be bad for vascular stability. And Ang2 is blocked by Furicimab. So in addition to being anti-VEGF, Furicimab is also anti-Ang2. So by being anti-Ang2 and anti-VEGF, you're contributing in a synergistic fashion to vascular stability. And the study results have been very promising. Phase 3 clinical trials, Yosemite and Rhine, have compared Furicimab and aflibercept for diabetic macular edema, and the results have shown non-inferiority and have been very exciting. And so these are very big trials that are going on right now, and there's a lot of excitement and optimism about Furicimab, and it's been submitted for possible FDA approval. So again, another treatment that around the corner potentially could be a newcomer to the field in how we approach these conditions. KSI 301 from Kodiak Sciences is another novel agent. It's an anti-VEGF antibody biopolymer, which is a very interesting concept. And we'll talk about what that is a little bit more here in a second on the next slide. But essentially, the antibody biopolymer conjugate ABC platform is engineered specifically for increased durability. And the GLEAM and GLIMMER studies were phase 3 clinical trials evaluating KSI 301 versus aflibercept currently for the treatment of diabetic macular edema. And these studies are ongoing. And early data has shown efficacy in longer treatment intervals. And so you're getting more durability with this new biopolymer conjugate. And it's a very interesting concept. This is kind of demonstrating what it is here. You have the antibodies and then this biopolymer that combine to form this combination. And essentially, it was engineered specifically for increased durability. Again, it has two components, the anti-VEGF antibody, and then it's covalently bonded to this high molecular weight kind of optically clear biopolymer. And the concept is to maximize intraocular durability by leveraging sort of size and dosing. And I think the estimation is based on the current formulations that you could have potentially 1,000-fold greater effect than a single intravitreal injection. And so the data will be very exciting to see how this biopolymer works. Now we're going to get into a whole different realm and approach to diabetic retinopathy, and that's gene therapy. And there's a lot of different angles to this, but REGENXBIO has their novel gene therapy, RGX-314, a virus vector designed to bind and neutralize VEGF in a manner similar to ranibizumab. The vector is taken up preferentially by retinal cells, leading to high levels of production of the antibody fragment. So essentially what they did in it, it's a very exciting and novel way of thinking about it is REGENXBIO and other companies looking at gene therapy are taking advantage of sort of this ocular biofactory approach. So you can deliver a gene that the eye doesn't normally make, anti-VEGF, for example, and you can inject it through a virus. The virus transfects the cells, delivers the gene, and that protein is now produced constitutively, nonstop. So you can deliver this virus into the eye and produce, for example, anti-VEGF at all times natively in the eye without additional injections. So a very novel and innovative way of thinking and approaching this. And with the success of other gene therapies now that are FDA approved, like Luxturna, and more data, longer term safety data coming out that patients are doing well and these treatments are safe, we're seeing more and more clinical trials now exploring this new area, this new realm of treatment. Altitude is a phase 2 clinical trial evaluating suprachoroidal injections of RGX-314 for the treatment of diabetic retinopathy without diabetic macular edema. And early data has demonstrated increased efficacy and durability with good safety. So very exciting. Obviously, there are concerns two people have, rightfully so, when talking about gene therapy. What will the long-term data look like? Are there consequences to having constitutive nonstop anti-VEGF produced in the eye at all times? Will we get less production over time? Will there be damage into the part of the eye where this therapy is delivered? There's a lot of questions, but the treatment's so far been proved to be very safe and efficacious, and the clinical trial results have been very promising. So we just talked about a suprachoroidal injection, but there are other mechanisms in which you can deliver gene therapy, subretinal, for example, or in the case of Advarium, intravitreal. So Advarium is another gene therapy which looks at an aflibercept coding sequence in contrast to the ranibizumab coding sequence in the RGX-314. And this treatment is delivered intravitreally rather than in the suprachoroidal or subretinal space. And you can imagine the benefits of that. Intravitreal injections are something we're very comfortable with. It's not a new technique or technology. And the thought of being able to do a one-time intravitreal injection that can produce anti-VEGF for who knows how long, maybe forever, is exciting. But it brings up a lot of questions and concerns as well. So the Infinity trial is a phase 2 clinical trial to evaluate the safety, efficacy, and durability of Advarium in patients with diabetic macular edema. We're getting more and more data out of that study as recently as, Academy, which wasn't too long ago, and Retina Society. And what's been shown is that while there was increased efficacy and durability, concerns have been raised because some patients, and particularly in the higher dose arms of the viral vector delivered, have had significant inflammation and hypotony that has required unmasking and surgery. And unfortunately, from the data being released and what's being said, it sounds like based on those adverse events, Advarium may be shifting now to focus on AMD rather than diabetic macular edema, thinking that perhaps there's less inflammation and maybe better results in that treatment paradigm. And so it may not be a player in the field of diabetic retinopathy, but certainly intravitreal gene therapy is something that's still being explored and something we'll watch closely. And this is just to kind of summarize the different current approaches to gene therapies, and who knows, in the future, maybe we'll come up with more, but you can deliver it intravitreally as Advarium was, or you can do the suprachoroidal space, which Regenxbio is doing and other companies. And then you can also go in the subretinal space, which again, Regenxbio is doing and other companies. So gene therapy is a very exciting field. I think we're seeing a lot of great things and a lot of really innovative clinical trials and utilization and approaches. But again, I think with more time, we'll get a better understanding of the safety and efficacy of this and what the real world data looks like. So in summary, diabetic retinopathy is a leading cause of blindness in working age adults. We know that diabetes and diabetic retinopathy are on the rise. Current therapies, while highly effective, have a high treatment burden, and there's room for improvement. And we've discussed that at length. We know we can do better, but the future is very promising. There's a lot of new potential therapies and delivery systems on the horizon. We're getting really innovative and all kinds of new things coming out. And so the future is bright and exciting. And I think within a few years, we may have some exciting new players in how we treat these patients, which is great. It's great for our patients. So that's all I have for you today. If you have any questions, please let me know. Again, it's been a pleasure talking to you all, and thanks for your time. All right. Hi, everyone. Welcome back to the Eyes on 2022 ophthalmology track. For those of you who just joined for this talk, you may recognize me. My name is Michael Ammar. I'm your moderator for today and all the prior sessions, but as a special bonus, I was also the speaker from the last talk. So I'll be moderating myself, and please bear with me. And please continue to drop any questions you may have in the chat box, as it's pretty much just me and you all. So I'm happy to discuss whatever and answer any questions you may have. A little more about myself. I'm currently a vitreoretinal surgeon at Retina Consultants San Diego and did my fellowship in Philly at the Wills Eye Hospital. I also did my residency in Philly at University of Pennsylvania Shea Eye Institute. And before that, I was back in Los Angeles at the University of Southern California. So happy to be back in sunny Southern California. I covered a lot in my talk. but really went through where we have been in regards to diabetic retinopathy treatment for years. And, that paradigm hasn't changed much. I feel like the way we manage diabetic retinopathy now is really similar to how we managed it 5-10 years ago. But, some of the studies I presented, like Panorama and DRCR Protocol W, maybe are shifting the way we currently use our equipment at this time, or what we have available to us, our armamentarium. And then, of course, at the end of the talk, I think it's exciting, always look to the future. I'm very involved in clinical trials, as many of us are, and there's a lot of really promising treatments around the corner. A great comment was made in the chat with the PDS system, sounding almost like an insulin pump, and in a way it is. It's a nice way to deliver medication slowly in a safe mechanism over a prolonged period of time. Some of those PDS patients going 6 months or so without needing another injection. So a lot of really innovative, exciting technologies. Gene therapy was something that just recently kind of launched onto the scene. Luxturna was just approved only a matter of years ago. And Luxturna, for those who are not familiar, is a gene therapy for people who have a form of inherited blindness. And that came out of a number of places, but that was kind of pioneered by Dr. Alan McGuire and Dr. Jean Bennett with others. And they were at the University of Pennsylvania Shea Institute when I was there for residency. And so that was a really exciting breakthrough. And after that, we've seen just a whole number of gene therapy options explode into clinical trials, trying to target all kinds of things, because the eye is a really unique target in that you can deliver local gene therapy into the eye without worrying about systemic absorption of it. And we have data that just came out recently from the Luxturna trials, which were the first FDA-approved gene therapies, about 4 years out now, and it's safe and patients are doing well. So I just think it's a really exciting time, and we're going to have some really innovative things happen probably in the next 5 to 10 years. But diabetic retinopathy isn't going anywhere. Unfortunately, it's becoming a bigger and bigger issue, and we're going to need to be innovative and be creative to find new ways to combat it. Obviously, no matter what we do in the eye, the most critical thing is education and systemic management, because we can do everything we want, but if they're out of control, they're going to have much bigger issues. No other questions in the chat. I don't have much else to talk about. So I'm just going to give you a couple of sign-off things that are important for you to know. I hope you enjoyed the talk. If any questions do come to mind, I put my contact information at the end of the talk there with my email. Feel free to reach out anytime. And this talk will be available afterwards. So if you missed part of it, or you need to rewatch it, or you'd like to have it as a reference, that'll all be available to you. It's also a CME lecture, so you can claim CME credit for this talk. But again, it's been a real pleasure chatting with you all day, and been an honor being your moderator. Thank you to everyone on Eyes On 2022. It's been a fantastic talk. Let's see, we did get a question, so I will pause. It says, it might be slightly off topic. How do you see the future of lasers like PRP or focal laser in the treatment of diabetic retinopathy with the advent of novel treatment modalities? Great question. Great question. Laser is like old faithful in diabetic retinopathy. It's been around forever and we still use it. And I love it because a lot of protocols have shown us, Protocol S, for example, in the long-term data, that laser works long-term, right? Injections are great. But if you get lost to follow-up, and COVID has shown this with a lot of papers, a lot of patients who were doing fantastic, getting injections monthly, came to every visit. When COVID hit, rightfully so, they became afraid to come in, their vision was great, or hospitals were closed down. There were all kinds of new barriers to healthcare. And because of that, the injections they were dependent on, they could no longer have access to. And we saw a lot of patients come back with significantly progressed diabetic retinopathy. The beauty of laser is that it provides a long-lasting protection. Nothing is perfect, but laser offers a lot more protection long-term if you miss visits than injections. It has some trade-offs. You can lose peripheral vision, things of that nature. But I still employ laser a lot in my clinic. If I have a patient who I know has a hard time with follow-up, if I have a patient who I don't know if I'm going to be able to trust will come in, I will lean a little more towards putting in PRP. If I have a patient who's monocular from a TRD that was poorly controlled in the other eye, missed visits, very early on, even at the severe NPDR stage, I will put in a full PRP because I really want to protect that monocular eye. And these are just a couple examples. So while I think there's going to be innovation, there's going to be exciting treatments, I just can't imagine laser not finding some utility in our field. It's just such a staple and so effective. So great question. Otherwise, thank you again, everyone. And if anything comes up, feel free to send it over. Happy to answer anything. In the meantime, again, you can head over to our exhibit hall or the innovation zone where we can have some raffles, prizes, all kinds of things going on. If you didn't catch the raffle codes earlier today, they are keratitis and nevus. So good luck to you all in the raffles, and don't forget about your CME credit. Thank you all for your time today. I hope you enjoyed the talks and the speakers as much as I did. Have a good night.